To diagnose anemia accurately, the evaluation must start with precise parameters. The World Health Organization sets the definitive baseline: hemoglobin strictly below 13 grams per deciliter for men and below 12 grams per deciliter for women. These thresholds are the absolute starting point for any clinical workup. From there, standard medical training relies heavily on this branching flowchart. It categorizes the anemia by mean corpuscular volume, dividing cases into microcytic, normocytic, and macrocytic based on the physical size of the red blood cells. But clinical data reveals the statistical failure of this model. In a study of over 4,000 patients, 85% fell straight into the ambiguous normocytic middle category. Furthermore, in patients with macrocytic cells, 90% had etiologies that the MCV alone failed to predict. Mixed deficiencies expose the physiological blind spot of this sizing model. If a patient has concurrent iron deficiency, which shrinks cells, alongside a B12 deficiency, which enlarges them, the opposing effects mathematically normalize the MCV. The test appears completely normal while the patient suffers from severe dual deficiencies. A proper initial workup requires moving past the CBC. Order an absolute reticulocyte count, a peripheral blood smear, and a complete iron panel, including ferritin, serum iron, total iron binding capacity, and transferrin saturation. Mean corpuscular volume remains a useful guide for the differential, but a physiologically sound diagnosis requires evaluating how the bone marrow is actually performing in real time. We have to evaluate kinetic marrow output rather than relying on static cell size. The absolute reticulocyte count is the single most critical piece of data following the initial CBC. It tells us exactly how the marrow is responding to the anemic stress. Looking at this comparison of a normal and an anemic blood vessel, we see the mathematical flaw in using raw reticulocyte percentages. Because the percentage is calculated against a heavily reduced red blood cell mass in the anemic patient, the exact same absolute number of reticulocytes yields a falsely elevated percentage. The denominator is broken. The marrow also reacts to extreme anemic stress by releasing shift reticulocytes. These are immature cells that exit the bone marrow prematurely. Because they enter the bloodstream early, they circulate longer than standard reticulocytes, artificially inflating the daily count. This formula calculates the reticulocyte production index, or RPI. It corrects for both the reduced red blood cell mass and the extended circulation time of shift reticulocytes, yielding an accurate measure of marrow output. The crucial variable here is the maturation factor, which scales inversely with the patient's hematocrit. A normal hematocrit of 45% uses a factor of 1.0. As anemia worsens, dropping to 35, 25, or 15%, the maturation factor increases to 1.5, 2.0, and 2.5, progressively correcting the mathematical distortion. Once the RPI is calculated, we use a definitive threshold of 2.0 to evaluate the marrow's capability. An RPI greater than 2 indicates a hyperproliferative state. The marrow is working exactly as it should, actively pumping out new cells. This points the diagnostic focus straight toward external red blood cell loss, specifically hemorrhage or hemolysis. An RPI strictly below 2 reveals a hypoproliferative state. The marrow is failing to mount an appropriate response to the anemia. This requires an immediate evaluation of the body's iron stores and building blocks. By applying the RPI correction to account for marrow stress, physicians prevent the critical error of misclassifying a failing hypoproliferative marrow as a fully functioning one. When evaluating a hypoproliferative marrow, ferritin serves as the gold standard marker for overall body iron stores, provided it is assessed in a vacuum. This grid isolates pure iron deficiency anemia. In a strictly non-inflammatory state, the diagnostic threshold is straightforward. A ferritin level that drops below 30 nanograms per milliliter definitively confirms absolute iron deficiency. The major clinical complication is that ferritin is an acute phase reactant. Any state of systemic inflammation, infection, autoimmune disease, or malignancy will artificially drive ferritin levels upward, masking a true deficiency. This occurs at the cellular level through hepcidin. Inflammatory cytokines stimulate the liver to produce hepcidin, which then actively blocks ferroportin receptors on enterocytes and macrophages. The iron is successfully absorbed, but it becomes physically trapped inside the reticuloendothelial system, unable to reach the marrow. Returning to the grid, we can observe how systemic inflammation forces a shift in the diagnostic threshold. To account for the trapped iron and artificially elevated ferritin, the cutoff to diagnose iron deficiency must move from below 30 strictly up to below 100 nanograms per milliliter. Pure anemia of inflammation presents a distinct lab pattern: low serum iron, low transferrin saturation, hyperferritinemia, and crucially, a low or normal total iron binding capacity. You contrast that directly with pure iron deficiency anemia, where the total iron binding capacity elevates significantly as the body attempts to capture any available iron in circulation. In clinical practice, patients frequently present with concurrent anemia of inflammation and iron deficiency anemia. You see this constantly in populations with chronic kidney disease or gastrointestinal cancers, where chronic inflammation coexists with ongoing blood loss. This cellular model shows the ultimate diagnostic tiebreaker: soluble transferrin receptor, or STFR. When cells are genuinely starved of iron, they shed these receptors into the bloodstream. Unlike ferritin, STFR ignores inflammatory signals entirely. It only elevates in true tissue iron deficiency. By dividing the STFR value by the log of the ferritin value, we isolate the deficiency. If that ratio is strictly greater than 2, it proves true iron deficiency is present, regardless of how much inflammation is clouding the rest of the iron panel. Interpreting an iron panel without contextualizing the patient's inflammation status guarantees that severe concurrent iron deficiency will go entirely unnoticed in chronically ill patients. This peripheral blood smear illustrates the microscopic validation of iron deficiency anemia. The red blood cells display microcytosis and hypochromia, accompanied by the presence of distinctly elongated pencil cells, also known as elliptocytes. Before these morphological changes ever appear on a smear, the CBC will show an elevated red cell distribution width, indicating variations in cell size, and a reactive thrombocytosis, where platelet counts spike early in the deficiency. Systemic iron deficiency degrades physiological function well before hemoglobin levels drop far enough to trigger an official anemia diagnosis. Patients with non-anemic iron deficiency experience significant neurological and behavioral symptoms. They suffer from severe fatigue, restless leg syndrome, and pica, a specific craving to consume ice, dirt, or starch that is present in up to half of all iron-deficient individuals. This clinical document outlines the most critical demographic rule regarding iron deficiency. The diagnosis itself is secondary to locating the cause of the iron loss. The absolute clinical mandate is this: unexplained iron deficiency anemia in postmenopausal women and in all men requires immediate bidirectional endoscopy, both upper and lower, to rule out gastrointestinal malignancy. Secondary causes for unexplained deficiency include impaired absorption due to celiac disease, H. pylori infections that decrease acid production, and autoimmune atrophic gastritis. Diagnosing iron deficiency is not the completion of the workup. It is a clinical alarm that requires identifying the exact source of the occult blood loss or the specific mechanism of malabsorption. This interconnected node map synthesizes the kinetic, morphological, and clinical data into a unified, actionable algorithm. It discards the flawed MCV starting point, anchoring the evaluation strictly to the World Health Organization hemoglobin definitions. It routes immediately to the reticulocyte production index, applying the maturation factor correction to accurately separate functioning marrows from failing ones. It forces physicians to contextualize the iron panel against systemic inflammation, shifting ferritin cutoffs and deploying the STFR ratio to catch hidden deficiencies. Precision in hematology relies completely on evaluating variables in their physiological context. You cannot interpret cell size, reticulocyte percentages, or ferritin levels in a vacuum. Internalizing this kinetic, context-dependent algorithm provides the framework required to strip away the noise, deduce the mechanism of the anemia, and locate the underlying pathology.